Hi guys, we were discussing about respiratory tract infections, right? So today let us start with bronchiolitis. First of all, coming to the definition, bronchiolitis is an acute viral infection of the lower respiratory tract of infants that affects approximately 50% of children during the first year of life and 100% by 3 years. Bronchiolitis is characterized by inflammatory changes in the small bronchi and bronchioles, but not by consolidation. So, this is particularly recognized as a disease of infants in the first year of life, in whom a small degree of airway narrowing can have a dramatic effect on airflow. However, the causal organisms are equally capable of infecting adults, who may then act as reservoirs of infection. Coming to the etiology, mainly our bronchiolitis is caused by the virus respiratory syncytial virus. So this accounts for up to 75% of the cases. And the second most common cause is the parainfluenza viruses. And bacteria serve as secondary pathogens in only a small minority of the cases. Coming to the clinical presentation of the patient that come across. So, signs and symptoms such as prodrome with irritability, restlessness, and mild fever. So, early symptoms such as irritability, restlessness, and mild fever can be seen with bronchiolitis. Also, you can see cough and coryza, vomiting, diarrhea, noisy breathing, and an increase in respiratory rate as symptoms progress. Labored breathing with retractions of the chest wall, nasal flaring, and grunting. So, labored breath means abnormal respiration, which is characterized by the evidence of increased effort to breathe. And grunting means low, rough sound. So, grunting at the end of each breathing indicates there is respiratory distress. On physical examination, we can find out tachycardia and respiratory rate of 40 to 80 per minute in hospitalized infants, wheezing and inspiratory rates, mild conjunctivitis in 1/3 of the patients, otitis media in 5 to 10% of the patients. And we can do the laboratory examinations and find out peripheral white blood cell count normally or slightly elevated, and on the arterial blood gas examination, we can see abnormalities such as hypoxemia and rarely hypercarbia. Coming to the treatment, so mostly bronchiolitis is a self-limiting illness and it usually requires no therapy at all. So we should provide reassurance, antipyretics, and adequate fluid intake for the patients. And usually bronchiolitis does not require any therapy unless the infant is hypoxic or dehydrated. So in the case of severely affected children, the mainstays of the therapy for bronchiolitis are oxygen therapy and intravenous fluid. So in case of severe infection, we should manage the infants with the help of oxygen and intravenous fluid. Then aerosolized beta adrenergic therapy, we can also treat with the help of aerosolized beta adrenergic therapy. And for the respiratory syncytial virus infection, we can treat with ribavirin, especially in severely ill patients, especially those with chronic lung disease, congenital heart disease, prematurity, and immunodeficiency. So, in case of immunodeficient patients, especially severe combined immunodeficiency and human immunodeficiency virus infection, so all these type of patients can be managed with the help of ribavirin. Now, coming to the next lower respiratory tract infection, that is pneumonia. So, coming to the definition, pneumonia is an infection of the lung parenchyma which can be viral or bacterial. So this is one of the most common infection cause of death in US. So it occurs in persons of all ages, although the clinical manifestations are most severe in the very young, the elderly, and the chronically ill patients. So the cause can be either bacterial or viral. Now let us see the pneumonia classifications and risk factors which leads to the development of pneumonia. So mainly pneumonia is classified as community acquired pneumonia, healthcare associated pneumonia, hospital acquired pneumonia, ventilator associated pneumonia. So let us see what are they. First of all, coming to the community acute pneumonia. So the pneumonia which develops in patients with no contact to a medical facility. So this is defined as the community acute pneumonia. So those who are at risk for developing community acute pneumonia, those who are having age more than 65 years, those who are having diabetic mellitus, asplenia, chronic cardiovascular, pulmonary, renal and or liver disease, and those who are having the history of or habit of smoking and or alcohol abuse. Now coming to the next one, healthcare associated pneumonia. So the pneumonia which develops in patients not in an acute care medical facility but two or more risk factors for multi-drug resistant pathogens. So in addition to the acute absence of acute care medical facility, the presence of two or more risk factors for MDR pathogens leads to the development of healthcare associated pneumonia. Let us see what are the risk factors. So if the patient is having the recent hospitalization of equal to or more than 2 days within past 90 days, then they are having the risk factors, they are more prone to develop the healthcare associated pneumonia. Then another risk factors are nursing home or long-term care facility resident, recent antibiotic use that is within past 30 days, chemotherapy, wound care or infusion therapy at either a healthcare facility or home. Hemodialysis patients, contact with a family member with infection caused by MDR pathogen, that is multi-drug resistant pathogen. Then there is then those who are in contact, they are more vulnerable to develop MDR pathogen associated pneumonia. Coming to the next one, hospital acquired pneumonia. So the pneumonia which develops more than 48 hours after the hospital admission. So if the patient is admitted to the hospital and then the pneumonia is developed within not within more than 48 hours, then we can say the patient is having hospital acquired pneumonia. So the risk factors are witnessed aspiration, COPD, ARDS or coma, administration of antacids, H2 antagonists or proton pump inhibitors, supine position, enteral nutrition, nasogastric tube, reintubation, tracheostomy or patient transport, prior antibiotic exposure, head trauma, ICP monitoring, age more than 60 years, and C. Healthcare associated for MDR risk factors. Coming to the last type, ventilator associated. So the pneumonia which develops more than 48 years after the intubation and mechanical ventilation, they are said to be ventilator associated pneumonia. So the risk factors are same for ventilator associated pneumonia as hospital acute pneumonia. Coming to the viral pneumonia. So the common causes of a viral pneumonia include influenza virus, adenovirus, parainfluenza virus, respiratory syncytial virus, and human metapneumovirus. So H1N1 and avian influenza A occur in pandemics and result in insignificant morbidity and mortality, with patients often requiring admission to the intensive care unit. The Patients who are having viral pneumonia may have symptoms such as dry cough, breathlessness, fever, headache, and myalgia. So, the diagnosis of viral pneumonia is made on clinical history, examination, culture of appropriate respiratory samples, and serological tests. So, the respiratory samples such as nasal secretions and bronchial lavage are collected, and for the diagnosis we are also using PCR based diagnostic panels, so they can detect the several respiratory viruses simultaneously. Along with that, blood test will show an elevated WBC count with a neutrophilia, a rise in CRP, and infiltrates or consolidation on the chest X-ray can also be found. And after an influenza infection, the patient are more vulnerable to develop secondary Staphylococcus aureus pneumonia. So, patients with viral pneumonia can develop secondary bacterial infection. So, this should be suspected if there is clinical deterioration, increase in the volume of sputum, which may be purulent, worsening breathlessness, and systemic symptoms. So, if the patient is having these all changes, we should suspect the bacterial infection following the viral pneumonia. Coming to the bacterial pneumonia, so this bacterial pneumonia is a common cause of morbidity in the community and a common presentation to the hospital. So it is important to distinguish between community acquired pneumonia and hospital acquired pneumonia, so as the latter is associated with a higher morbidity and mortality. So let us see what are the causative organisms for bacterial pneumonia. So bacteria such as Streptococcus pneumonia, Haemophilus influenza, Legionella pneumophilia, Mycoplasma pneumophilia, gram-negative organisms such as Proteus, E. coli, Staphylococcus aureus, Klebsiella pneumonia, Pseudomonas aeruginosa, Coxiella burnetii, Chlamydia pneumonia. This all can lead to development of bacterial pneumonia. Coming to the clinical presentation of bacterial pneumonia, so you can see there is abrupt onset of fever, chills, dyspnea, that is shortness of breath, and productive cough. Also, you can see the rust-colored sputum and hemoptysis, pleuristic chest pain. So these are the main signs and symptoms of the bacterial pneumonia. Coming to the physical examination, you can see tachypnea and tachycardia in the patient. On percussion, we can see dullness and increased tactile parameters, whispered pectoraloquy, and egophony. So, tactile parameters means an assessment of the low frequency vibration of a patient's chest. So, which is used as an indirect measure of the amount of air and density of tissue present within the lungs. And whispered pectoraloquy means an increase in the loudness of whispering, which is noted during the auscultation with stethoscope on the lung fields. Whereas egophony is the increased resonance of voice sounds heard when auscultating the lungs, often caused by lung consolidation and fibrosis. You can also see chest wall retractions and grunting respirations, diminished breath sounds over the affected area, inspiratory crackles during lung expansion, and in chest radiograph you can see dense lobar or segmental infiltrate, which indicates infection. And in laboratory examination you can see leukocytosis and low oxygen saturation. And in leukocytosis you can see there is predominance of polymorphonuclear cells, and with the help of arterial blood gas or pulse oximetry we can find out the oxygen saturation in the patient, and in case of bronchiolitis you can see low oxygen saturation. Coming to the pathophysiology, so before that, how these microorganisms or the causative agents enters our body. So there are mainly three routes. that can be inhaled as aerosolized particles, first one, or second one, they may enter the lung via the bloodstream from an extrapulmonary site to the site of infection, and third one, aspiration of oropharyngeal contents may occur. So these are the three routes by which a microorganism enters our respiratory tract, especially lower respiratory tract. So let us see the pathophysiology of viral pneumonia. So the most common causes of these are adenovirus, influenza virus, parainfluenza virus, etc. Right? So acquisition of viruses is by direct contact, droplet transmission, or aerosol exposure. So there is initial destruction of the ciliated epithelium of the distal airway with the sloughing of cellular material. Initially, the viruses which entered our lower respiratory tract distracts the ciliated epithelium of the distal airway, which removes the cellular material. A mononuclear predominant inflammatory response occurs as a result of this, and in the interstitium initially and later may involve the alveoli as well. So initially the response occurs in the interstitium, and later alveolar response can also occur. Now coming to the pathophysiology of the bacterial pneumonia. So the bacterial pneumonia usually begins with the aspiration of the nasopharyngeal bacteria. A preceding viral infection sometimes sets the stage for bacterial infection by causing epithelial damage, reduced mucociliary clearance in the trachea, and major bronchi and a reduced immune response. So the bacteria can enter the lower respiratory tract can through aspiration of nasopharyngeal contents. So, as a result of the previous viral infection, the patient may have the chance to develop bacterial infection, right? So, this can cause epithelial damage, reduced mucociliary clearance in the trachea, and in the major bronchi, and a reduced immune response. So, the mucociliary clearance in the trachea and major bronchi is reduced, so which helps the bacteria to proliferate. So once in the alveolar region, bacteria encounter local host defenses such as antibodies, complement, and cytokines, which prepare the bacteria for ingestion by alveolar macrophages. So once the bacteria enters the alveolar region, our alveoli is having our primary defense cells such as macrophages. So as a result of the bacterial infection, antibodies, complements, and cytokines are prepared by the alveolar macrophages for the destruction of the bacteria. Alveolar macrophages recognize the bacteria with their surface receptors and phagocytoses them. So, our alveolar macrophages are having surface receptors. So, with the help of surface receptors, they phagocytoses the bacteria. So if these mechanisms fail, macrophages release numerous inflammatory cytokines and neutrophils. This will be recruited into the lung. So initially our alveolar macrophages try to destroy the bacteria with the help of phagocytosis, and if this mechanism fails, our body produces numerous inflammatory cytokines, neutrophils. So with the help of this, further destruction of the bacteria promotes. An intense cytokine mediated inflammation will ensue. Vascular engorgement, edema, and a fibrinopurulent exudate occurs. So as a result of this, you can see cytokine mediated inflammation, and following this vascular engorgement, edema, and the exudate formed will be fibrinopurulent in nature. Alveolar filling precludes gas exchange, and if extensive can lead to respiratory failure. So there is exudate formation, and this can lead to filling in the alveoli, so there is difficulty in the gas exchange. And if this condition extends, what happens? This can lead to respiratory failure. If sepsis occurs at the same time, shock and end organ hypoperfusion will cause metabolic acidosis. So these are the changes which contributes to the bacterial pneumonia. Coming to the treatment, let us see the empirical antimicrobial therapy for pneumonia in pediatric patients. So those who are having less than 1 month, we can manage with ampicillin, sulbactam, cephalosporin, carbapenem for usual pathogens such as group B streptococcus, Haemophilus influenza, E. coli, Staphylococcus aureus, and Listeria. And for for organisms such as respiratory syncytial virus, we can manage with ribavirin. Then 1 to 3 months, we can manage with macrolide, acylide, trimethoprim, sulfamethoxazole for organisms such as C. pneumoniae, possibly urea plasma, CMV, pneumocystis carni. Then in case of Streptococcus pneumonia, Staphylococcus aureus infections, we can manage with semisynthetic penicillin or cephalosporin. In case of preschool aged in children, viral pneumonia is more common. So organisms such as rhinovirus, RSV, influenza A and B, parainfluenza, adenovirus, human metapneumovirus, coronavirus can be managed with antiviral agents, and antimicrobial therapy is not routinely required. So we can provide the symptomatic and supportive measures. So previously healthy, fully immunized infants and preschool children with the suspected mild to moderate bacterial CAP, community acquired pneumonia, we can manage with the amoxicillin, cephalosporin, macrolide or acylide or fluoroquinolone. In case of previously healthy, fully immunized school-aged children and adolescents with mild to moderate CAP, if the causative organism is Streptococcus pneumoniae, we can treat with amoxicillin, cephalosporin or fluoroquinolones. Whereas for organisms such as Mycoplasma pneumonia and other atypical organisms, we can manage with macrolide or acylide, fluoroquinolone or tetracycline. For moderate to severe CAP during influenza virus outbreak, we can manage with oseltamivir or zanamivir. So which are the antiviral drugs, especially for influenza A and B and other viruses. So for inpatient or community acquired cases, fully immunized infants and school-aged children, we can manage the treatment with, we can provide the empirical therapy with ampicillin, penicillin G, cephalosporin if we suspect organisms such as Streptococcus pneumoniae. And for CAMRSA pathogens, we can treat with beta-lactam plus vancomycin or clindamycin. And for M. pneumonia and C. pneumonia, we can treat with beta-lactam plus macrolide or fluoroquinolone or doxycycline. Not fully immunized infants and children, regions with invasive penicillin-resistant pneumococcal strains, patients with life-threatening infections. For these cases, we can manage with cephalosporin, vancomycin or clindamycin, macrolide or acylide plus beta-lactam or doxycycline or fluoroquinolone. Coming to the antibiotic doses for the treatment of bacterial pneumonia. So these are the common antibiotics which are used in the management of bacterial pneumonia. So antibiotics such as penicillins, extended spectrum cephalosporins, macrolide or acylide, fluoroquinolones, tetracycline, aminoglycosides, carbapenems and other antibiotics are also used. So penicillin such as ampicillin plus or sulbactam, amoxicillin plus or clavulanate, piperacin or tazobactam and penicillin are used for pediatric as well as adult patient. And In case of extended spectral cephalosporins, we are using ceftriaxone, cefotaxime, ceftazidime, and cefepime. And among macrolide or acylide, we are using clarithromycin, erythromycin, and azithromycin. Moxifloxacin, gemifloxacin, levofloxacin, and ciprofloxacin are the useful fluoroquinolones in the bacterial pneumonia. Tetracyclines such as doxycycline, tetracycline hydrochloride are also used. Aminoglycosides such as gentamicin and tobramycin are used. Carbapenems such as imipenem, meropenem are used. And other antibiotics such as vancomycin, linezolid, and clindamycin can also be used for the management of bacterial pneumonia. So this is all about lower respiratory tract infections. So our respiratory tract infections are finished. Now you must have understood about upper respiratory tract infection as well as the lower respiratory tract infection and how to manage all these conditions. Thank you.